my focus is going to be on liver cancer, and thank you very much for coming. And some of the slides that Dr. Ascher showed are almost identical to the ones I'm showing today. You pass it really quickly. So the official term the technical term for liver cancer is hepatocellular carcinoma. Hepatic means liver, cell carcinoma is a more technical term for cancer. So it's a worldwide epidemic. So when you look at the global distribution of liver cancer, it's really interesting that it follows or parallel areas that are very endemic for hepatitis B. So in areas that are endemic, with very high prevalence of hepatitis B, the cancer incidence is also the highest. So examples would be Asia, China, Southeast Asia, and also Sub-Saharan Africa. Okay, in some of these places, for instance, in Asia, 1 out of 10 individuals are infected with hepatitis B. So these red areas are areas that are very high prevalence for liver cancer, and the numbers are astounding. You can see here 10 to 100 per 100,000 people in the population. So 1 in 1,000 to 1 in 10,000. So that's an enormous problem. So we live in a country where the incidence of liver cancer is relatively low, but you should know that it's definitely increasing. Okay. So here are some of the facts. Okay, liver cancer is the 6th most common cancer worldwide and the 3rd leading cause of cancer-related death. Okay, so it's very important. And we mentioned about Asia, Sub-Saharan Africa. Just in those 2 places alone, every year, greater than 500,000 new cases of liver cancer develop every year. Okay. And we know that the incidence of liver cancer is rapidly increasing in Western countries, including the United States, and also in the developing world. Okay. So most of the cases are predictable, so to speak. So there's a reason for these individuals to develop liver cancer. We'll talk about that. So why do people develop liver cancer? Who's at risk? So as Dr. Ascher already alluded to, it occurs in the background of chronic liver disease. I'm just mentioning a few examples: hepatitis C, fatty liver, alcohol, metabolic inherited disease. There's a variety of these metabolic or genetically based inherited forms of liver disease, like hemochromatosis, which is a disorder of iron overload, Wilson's, which is copper, and a number of other things, particularly in the pediatric population. They may not be at risk for liver cancer, but some of them are. And the hepatitis B, there's another category we call cholestatic liver disease, like primary biliary cirrhosis, primary sclerosing cholangitis. The risk is somewhat lower. So the natural history is you need chronic liver disease, and over time what happens is that you see consistent repeated injuries to the liver cells, the healthy liver cells. So in some patients, they develop cirrhosis. Cirrhosis is a term that means that there's a lot of injury replaced by scar tissue. These scar tissues can form nodules we call regenerative nodules, and within these nodules there may be transformation to develop cancer over time. So a typical scenario would be hepatitis C, for instance. It, on average, takes about 20 years to develop cirrhosis or scarring, on average about 10 years to develop liver cancer. There's a wide range in the timetable. So the sequence is typically chronic liver disease of various different etiologies, cirrhosis, and then liver cancer. One notable exception, hepatitis B. Okay. So hepatitis B can bypass this stage of cirrhosis and develop liver cancer directly. So that's an important consideration when we talk about screening as well as management. So we're now faced with 3 epidemics in liver disease. Dr. Ascher already talked about that. Hepatitis C, dealing with about 5 million individuals in this country. Fatty liver, we see the map about people with high BMI, so it's clearly linked to obesity. That's a problem, increasingly difficult problem that we face with. And a typical patient with fatty liver has obesity or significant weight gain over the years, type 2 diabetes and insulin resistance, and high lipids, primarily triglyceride, which is a reflection of dietary fat intake. So you have the combination of 3. We call that full metabolic syndrome. So fatty liver is a a huge problem now. We say, so it's an epidemic. We used to kind of ignore fatty liver, thinking there's a benign condition. Now we all know it's a serious problem. In fact, fatty liver just surpassed hepatitis C as the leading cause of liver cancer in this country. So with those two, the third epidemic is liver cancer. I can tell you that we are clearly, I've been here for 12 years, we are clearly seeing more and more liver cancer patients. And so this past year alone, we saw 250 cases of liver cancer. And we have a tumor board, as we talked about. So every week we review cases with liver cancer for transplant or other treatment options. And every week we review about 20 to 40 cases. So it's become a huge problem for us too. So everything starts with screening. The idea of screening is to really detect liver cancer at the earliest stage possible so that you can intervene, so you can offer treatment of curative intent. That's the whole idea about screening. So if you don't screen, you don't detect it at early stage, and sometimes when the patients become sick or symptomatic from liver cancer, it may be too late. So let's concentrate on the one group, the hepatitis B group first. As I mentioned, they don't need to go through cirrhosis to develop liver cancer. So patients with chronic hepatitis C can develop liver cancer, and some at very young age without cirrhosis. And for individuals from Asia, for instance, up to 40% of patients who have liver cancer don't have underlying cirrhosis. Okay? So in the United States, for instance, 90% of hepatitis B infected individuals are originally coming from Asia. We know that hepatitis B vaccination would change the landscape over the next 50 years, maybe to reduce the incidence of hepatitis B to a minimum, but we still have to deal with people who are born after 1992, at least in this country, where vaccination, all the newborns were implemented, and in the late 80s in Asia, where they started vaccination. So it's still a problem in the next 25, 50 years. So there's some guidelines that are being out there from like the American Association for Study of Liver Disease, and these guidelines are screen for liver cancer in patients who are infected with hepatitis B if they have any one of these categories. If they have cirrhosis, family history. I've seen a whole family with liver cancer, brothers, siblings, parents, so the risk is much, much higher. They have active disease measured based on the liver enzyme or ALT and the viral load. And then age is a factor. The older the person is, the greater the risk. We generally use cutoff 40 for men, 50 for women, and somebody with hepatitis B who come from Africa start screening at the age of 20. You know, those patients have very aggressive form of liver cancer. So in clinical practice, so I have a clinic where I see a lot of patients with hepatitis B from Asia because of my ability to communicate with many of them. And to make life simpler, I think these are just minimal requirements. I screen everybody, okay? So instead of just selectively screen them, I screen everybody. Somebody who's lower risk, say a 20-year-old with inactive hepatitis B, they're still at risk, so I screen them. Perhaps lower frequency, maybe once a year, as opposed to every 6 months. So this is kind of a wake-up call. We used to have very limited treatments available for hepatitis B 15 years ago, and now we have a variety of different very good treatments that are very effective in suppressing the virus, not necessarily curing it. A lot of these patients need long-term treatment. But this is a huge study coming from Taiwan. In those countries, the incidence of liver cancer is extremely high. And you see the incidence of liver cancer across the hepatitis B DNA gradient at baseline. The higher the viral load at baseline, the greater the risk for developing liver cancer. You have viral load greater than 1 million. This is the risk for developing liver cancer over 10, 15 years, much higher than those with lower viral load. So this needs to be confirmed, but it may have important implications for treatment to lower the risk of developing liver cancer in these individuals. So in patients who don't have hepatitis B, who have other types of liver disease, I think screening should be focused on those who already have cirrhosis. Now, we don't necessarily need to screen everybody before they reach the stage of cirrhosis unless they have hepatitis B. But for those who already have cirrhosis, we can usually tell either based on biopsy or by examining the patient, looking at the blood test. If they have suspected cirrhosis, start the screening process. The risk is lower in certain types of liver disease, for instance, primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis, Wilson's disease, but they still need screening. But the risk may be a little bit lower. So how do we screen? The standard recommendation is ultrasound, alpha-fetoprotein every 6 months. So ultrasound, simple, no radiation, really no risk, and it's a good screening test. So this is a patient with in the right clinical setting who has a lesion in the liver, turned out to be liver cancer, so that's important. So is screening important? Well, it's hard to do studies to say you don't screen patients and let them develop liver cancer, but there was an old study from 20 years ago from Shanghai, China, suggesting that if you do screening, any kind of screening, you lower the mortality, the death rate by 37%. As opposed to people who never received screening. These are primarily patients with hepatitis B. So there's some evidence suggesting that screening is important in reducing the chance of death in these patients who are at risk for developing liver cancer.